I'd like to introduce Jane Bollen. Put my glasses on so I can read. Jane's an experienced practice nurse who works in Adelaide. She's part of the APNA Building Nurse Capacity Program, runs a clinic on healthy ageing. She's a past director of the APNA board, 2016 to 2018, and has represented APNA at AgPal Healthcare Homes, Resource Development and Workshops, My Health Record Expansion Steering Group, and now the RACGP Standards Committee. I'll have to talk to you later because I'm just doing accreditation. Jane has a particular interest in osteoporosis and bone health and regularly attends local and international meetings on this topic. I'm looking forward to this session. We do the REFRAME program in our practice and it's really worthwhile. Please welcome Jane.
Thanks, Peter. Well, you mightn't recognise me today if you were there last night. Anyway, let me, just a bit of a disclaimer. And yes, Amgen have asked me to speak today, so I'll just turn my phone on. Great. All right. So what I want you to get out of today, I want you to understand the impact of osteoporosis on our patients and ourselves really. But we want to know how to find those patients at risk of fractures in our practices. But we also, as nurses, need to know how we can manage our patients better in our practices. So a little bit about myself. I'm working at Allenby Gardens family practice. We've got 2 GPs and 3 nurses. And we're not all full-time, but we're building that nurse capacity because we can see that we've got almost 3,000 patients and 10,000 of them are over 75. So we're really trying to target that ageing group because we know that, you know, the 80-year-old man actually can come to the practice on average from the beach data 20 times a year. And so we want to actually help those patients manage their own conditions and for their own sake try and limit the amount of times that they're coming back to the GP all the time. So we're looking at the frail elderly, and frail, I mean, we ask them, are you fatigued? Are you having difficulty walking up 10 stairs? That's resistance. Ambulation. Are you having difficulty walking around the block? I. Have you got 5 or more illnesses? L is loss of weight in the last 6 months. So once we deem them at risk of frailty, we start getting processes in place to actually help them. And those that are actually frail, we work with them as well. So we're looking at their walking speed because that's been shown to be a better indication of longevity than blood pressure in the later years. We look at their nutrition, we look at their cognition with a GP cog and a depression score. We're doing it through health assessments, care plans and care coordination. So the coordination, we're trying to ring the patients in between to actually help them with their management of their conditions. Well, lo and behold, we found osteoporosis is prevalent in this group, but also across the practice. So we're trying to work with both things together. So osteoporosis, the scale of the problem is really big, much bigger than you'd imagine. We'll talk about who's at risk. So we'll be looking at those patients that have perhaps gone off their medication. We'll be looking at the group that we're trying to stop that first fracture. And then those that have already had a fracture, we'll be trying to stop the second one. And then we'll be looking at the management of osteoporosis. So this is a slide that I quite often show my patients. This is what healthy bone looks like, and this is what the osteoporotic bone looks like. This is what happens after the age of 70 for men, and for women it's much younger, and especially if people have got other contributing factors. This is a another lovely slide. Now, just having a look at these, we're actively growing our bones for the first 30 years, and then we've got a slow loss from 30 to 40, and then it happens a lot more rapidly for women after 50, and then after 60, even more rapid. For men, the decline's not quite the same, but it is still there, so we have to look for our male population as well. So, okay, all right. Could I just get everyone to stand up, please? I know, it's difficult after that big night last night. Okay, sit down if you're under 50. I know, look, we don't mind sharing our ages, but if you've sat down because you're politically correct, that's okay. But just looking around the room, 2 out of 3 of you have either got osteopenia or osteoporosis. So this is why we really need to pick it up. It's actually a lot more prevalent than diabetes. So you can sit down now. So this means there are 4.7 million people in Australia affected with osteoporosis or osteopenia. They're the statistics on how often these fractures are occurring. But taking it back to my own practice, and this is what I want you to know. I want you to know how many potential patients you have in your own practice and how we're going to find them. So we've got 1,200 people over the age of 50 in our practice. So I suddenly realised we've got potentially 860 patients that are at risk or have got osteoporosis. So fractures are the serious consequence of osteoporosis. Fractures actually lower the quality of life for people, but more importantly, there's increased mortality. So, you know, we're seeing these people all the time. So following a hip fracture, greater than 50% of people that survive will be actually using walking aids. 60 to 80% need assistance with daily living. 10 to 20% will end up in aged care facilities, but this is where it's really sad, 25% will die within 12 months. So who's at risk of fracture? Well, we know people with older age, people with low bone mineral density T-scores, and also if they've had a minimal trauma fracture. They're major risk factors for a future fracture. A fracture begets a fracture. So this is reflected in some of the PBS data, and so people over the age of 70 and people with T-scores less than or equal to minus 2.5, or they've had a prior minimal trauma fracture, and we'll go into that in a bit more detail. So looking at this, there is a huge gap in our osteoporosis care. Osteoporosis is underdiagnosed, undertreated with potentially poor physical, psychosocial, economic outcomes. So just thinking of, you know, a hip fracture, what a strain on the health system a hip fracture is. So what we can do in primary care to actually avoid that hip fracture, it's a whole of team approach. It's not just the GP, it's not just the nurses, it's everyone in your team. It's the reception staff, it's the practice manager, it's the nurses, it's the GPs, all working together, and then using the experience of the allied health as well. So I'll just have a little sip of water. So up to 80% of women and 90% of men with minimal trauma fractures are not treated to prevent further bone loss and fractures. So they're in our practices, they are there. So a retrospective audit of people presenting to Australian public hospitals found that 10% of patients were investigated for osteoporosis, 12% of patients were started on treatment with calcium and vitamin D, and 9% of patients were given specific anti-osteoporotic therapy. There are very few fracture liaison clinics around Australia, and I'm not aware of any in Adelaide. So we need to prevent fractures in patients at risk. So we know that medication actually decreases high bone turnover. So we also know that we need adequate calcium and vitamin D as well. So if we're not getting enough in our diet, we're not getting enough sunlight, we need supplements. We need a healthy lifestyle, incorporating appropriate diet and weight-bearing strengthening exercises. And we need to prevent falls. So how are we going to target those at high risk? So we need to ensure patients diagnosed with osteoporosis remain on their treatment. We need to identify those at the risk of their first fracture, as well as finding those with a prior minimal trauma fracture to prevent further fractures. So this first group, that they're non-adherent, they might have been on medication in the past, and they haven't stuck to it, you know, and taking medication is difficult. And, but what we found, or what the studies have found, that even if you drop 25% of your medication, you have decreased your ability to regrow bone quite significantly. And if you've missed it for a significant period of time, well, there's no effect. So, for example, like Prolia injection, you know, they've got a 6-month a 4-week window either side of taking that medication. We need them to adhere to their medication. So these are the different medications that are out there, and this is their adherence. You will have access to these slides, and this video will go up on the website later as well. So feel free to take pictures, but these slides will be available to you. But this is what we're concerned about. We're concerned about people dropping off their medication. The next group, we've got to prevent that primary fracture prevention. So I have one of these on my desk. And I love being a nurse because we can have as many tools and things. And of course the GPs can as well, but perhaps it's not in their nature as well. But I always have this on my desk so that when I've got a patient that I'm concerned about, I can actually work through that flow chart. And so when the GP comes into me at the end of the care plan, I can actually say, oh, this is where the patient fits, you know, and it just also, there's a lot to remember, and our clinical software isn't too intuitive at this stage. So make sure you go to the REFRAME stand and grab one of these because they're a great tool to have on your desk. So we want to reduce the risk of the first fracture. So these patients haven't had any history of a minimal trauma fracture. So if they're 70, they go straight to have a bone density. But we're trying to find those patients that are over 50 with a major risk factor as well. And they will all have a bone density assessed by, they're recommended to have a bone density assessed by the DEXA. So if their T-score's less than or equal to minus 2.5, they go straight to treatment. If it's greater than minus 2.5, we've got to use a couple of tools to calculate their risk fractures. If it's at high risk, they too can go on to medications. It's recommended. But then our role comes in assessing the falls risk, the exercise, the lifestyle factors. So who's at risk? Look at this. The non-modifiable ones. So we've got to start asking our patients, have you had a parent that's had a hip fracture? Because you're at risk now. People greater than 70 are at risk. The modifiable lifestyle, people that are low testosterone, premature menopause. So if you reach menopause before 45, you're at risk. People low physical activity or immobility, so that's more and more of our population. People that are under with protein and calcium in their diet. Excessive alcohol, that's greater than 2 standard drinks. Vitamin D insufficiency. The conditions we've got to start looking at. Rheumatoid arthritis, patients with hypothyroidism, hyperparathyroidism, chronic kidney disease. Now we know this is really undetected in our patients and uncoded in our software. So we've got to get better at coding our conditions, and chronic kidney disease is one of those that after you've found those patients with osteoporosis, we'll go back and find the patients with kidney disease. Liver disease, people with celiac, malabsorption disorders, even diabetes and myelomas. The medications, patients on corticosteroids, and look at these other ones, SSRIs or PPIs, proton pump inhibitors. You know how many of our patients are actually on those. So these medications are affecting their bone strength as well. So the little ones with stars, there's actually an MBS item number. There is a rebate for patients having a bone mineral density. Some of the others may have to pay. So, anyone had a bone density? Oh, that's good, that's good. And so we explain to our patients what the DEXA machine looks like, that it's much easier than an X-ray. They'll be able to wear their own clothes to, they can just, quite often just wear a loose-fitting outfit, maybe no zips or buttons around the hip or the spine. And I explained to them that the radiographer will be taking a photo of their hips and the base of their spine. And it's important for them to be going to the same DEXA, you know, for revisits so that there can be comparisons along the way. So if they start at one service, it is important to sort of continue with it. A lot of our patients use the Queen Elizabeth Hospital here, and they follow them up as far as every time they're comparing their T-scores. So what's a normal T-score look like? So normal is -1 and above. It's always pretty tricky that T-scores are in negative values, but once you get used to it, you'll get the hang of it. Low bone mass or osteopenia is -1 to -2.4, and then osteoporosis is less than -2.5 or equal to. But the T-score cannot be the only indicator of osteoporosis. We've got to look at other risk factors as well. So there are these two tools. There's the Garvin and the FRAX. And when we're having our bone densities at the Queen Elizabeth, they actually include the FRAX score. But, you know, actually preparing for this presentation, I've actually started playing around with these both a lot more. And so because I'm familiar with the FRAX score, because the patients are having it, I'm sort of sticking with that at the moment. But the Garvin is another, one was set up in the UK and one's more Australian-based, but the FRAX, which was UK, has been adapted to Australian conditions. So why use a calculator? A fracture risk calculator can assess patients at risk with a bone density between -2.5 and -1.5, but with risk factors for a fracture. They can be useful for when discussing their fracture risk with a patient. You know, how we use OSD risk or cardiovascular risk, we can start using these FRAX or the Garvin with our patients to actually explain to them where they sit and where their risk factors are. So this is the difference in the two different systems, but you know, have a look at them, just pull them up on your desktop, you know, bookmark them so that when you're discussing with your patient that you can actually look at this. So here we have Samira. Now, can anyone tell me, just looking at some of her, she's female, she's age 77. Just looking at her picture, has she got any other risk factors? Very good, yes. Low vitamin D, she's covered. Her mother fractured her hip at age 76, so there we are, there's a risk factor as well. Her weight, 68 kilos, height 167, and I have a guess her bone mineral BMI is probably normal there. But she's recently been diagnosed with Graves' disease, which is hyperthyroidism. So there's another risk factor. She's a non-smoker, non-drinker, so that's good. She hasn't got any history of fractures herself, but she's on an antidepressant, and we know that some of the SSRIs can contribute to bone health. She's had 2 falls in the last 12 months, and her bone mineral density is minus 2.3 at the femoral neck. So that puts her in the osteopenic range. So we need to use a calculator to actually work out what's happening with her. So looking at the fracts will actually look at, put a lot of those things into the calculator. So it's actually looking at the parent fractured hip, and then secondary osteoporosis. She's got a risk factor, the hyperthyroidism. So her major osteoporotic at a risk at 10 years is 24. So she's at high risk. So looking at the Garvin, it's similar but a little bit different. So looking at our next group, we're trying to prevent the secondary fracture. So we're actually looking for those at risk that have had a minimal trauma fracture. So if they've had a minimal trauma fracture, it's straight away it's a presumptive diagnosis of osteoporosis, and they can start treatment. If they've had a minimal trauma fracture at their wrist or somewhere other than their hip or vertebral fracture, we can send them off for a bone density and then work our way down and have a look at whether they start on treatment, and then looking at their falls risks and lifestyle factors. So having a fracture increases the risk of further fracture. With every osteoporotic fracture, there is a 2 to 4 times increased risk of repeat fracture. With every repeat fracture, there is 3 to 4 times increase of premature mortality. So it is serious. So what is a minimal trauma fracture? So it's easily defined as a fall from standing height or less. So we ask our patients, were you surprised that you broke a bone because you didn't think it was a serious fall or accident? Or we say to them, you know, if you were 25 and you had this fall, do you think you would have broken a bone? And quite often that is an indicator, and they go, no, actually, you know, I would have bounced straight back, you know, but yes, I was surprised. So significance of vertebral fractures. Vertebral fractures are the most common osteoporotic fracture. The estimated prevalence is up to 50% of women aged 50 years have a vertebral fracture. The majority of vertebral fractures do not come to clinical attention. Many vertebral fractures do not have clear symptoms. Only 1/3 result from falls. The majority are routine activities like picking up those grandchildren or shopping bags. It can be as minimal as that. A patient with a vertebral fracture today is at increased risk of becoming a patient with a hip fracture in the future. The risk of a hip fracture increases 2 to 3 times after a vertebral fracture. So how are we going to identify vertebral fractures? You know, we as nurses are actually dealing with these people all the time. And so we need to actually make sure we're recording their heights. If patients have had a decrease in their height of 3 centimetres or more, they need an X-ray. It needs to be confirmed with an X-ray. You know, when we're checking their height and their head doesn't quite reach the back of the wall, well, that can be another indication. Their kyphosis is starting. You know, a new onset of back pain with no identifiable cause can be another reason. So these people need to have an X-ray. So how important are those height measurements? And just in our own practice, we have found so many people in the last 12 months just by persevering, doing a height every time we do a care plan or a health assessment. Our clinical software is not that good, is it? Because I know with medical director, if you're just weighing somebody, they actually carry the height over. So that person mightn't have had a height for 10 years, but actually it's still being reported as what it was 10 years ago. So this is where we really come in. We're managing these people. You know, these people all need to be on care plans so that they can be spending time with the nurses. So imagine that, patients with osteoporosis, everyone in that practice coming to see the nurses. We actually, you know, how many nurses do we need to deal with this problem? So, you know, for us that transition from hospitals, we had to know who was in our ward. So in general practice, we need to think who is in our practice. We've got to be looking at everybody. This is so important. It's not just the person in front of us that's been put on the booking sheet. We've got to be spending some time actually looking at our data. It's going to become so much more apparent with, you know, the PIP guidelines. We as nurses are going to have to know how to use PenCat or what other clinical audit tool you've got in your practice. We're going to have to actually show improvements in how we're finding these patients and you know, diagnosing as a team. So this is called population management, and as you heard, you know, I was involved in the healthcare home, some of the writing of and this is one of the building blocks of the patient-centred medical homes. This is a really important part, and I think as nurses we need to claim this. We've got to be proactive versus reactive, and the goal is to ensure that every patient in our practice receives the care they require and to reduce the care gaps for a practice population. So we've got to actually stagger those patients that are coming really frequently and work with them well when we see them. Don't keep on making them come back and back, but we have to start making room for some of those others that aren't coming to our practice quite as often and invite them in. So we've got to identify our population. Who is in our herd? You know, identify the patients with osteoporosis. Start building that register. So how are we going to do that? We need to deactify anyone in our practice that hasn't been for 3 years, or that's how we're doing in our practice. The College of GPs has active population as a patient that's been 3 times in the last 2 years, but we're actually being a bit more lenient than that. We're saying anyone that's been in our practice hasn't been for 3 years, we deactify them. Anyone that lives outside interstate postcodes, we deactify them. Deceased patients, you know, we've got to have protocols and systems in our practices that the reception staff, the practice manager knows how to deactify them. So how it started a few years ago, before I heard about the REFRAME program, I am a bit of a data queen, and I do like looking at the practice data. I was just flipping through PenCat, and usually I use the Cat4, but I saw this cleansing view, and it was really interesting because it had patients with diabetes, with indicated diabetes, without a diagnosis. And I thought, oh, okay, I'll look at that. And then kidney disease. And then I found osteoporosis as well. So indicated osteoporosis with no diagnosis. So this has actually made me start looking and thinking, oh my gosh, we've got patients in our practice. And so it's quite good, you know, that it actually indicates when the fracture risk if it's been coded in there. It also looks at the bone density, but this is one of the tools that we can use. And I'll go into the REFRAME program because that's even nicer. So at our practice, the GPs I work with are really lovely. We've got our care plans down to a fine art, and our GP explains to our patients At our clinic, we have planned care for our chronic conditions. That is, every 3 to 6 months, you'll have an appointment with the nurse in consultation with me. We will look at your care plan, how you're tracking, and make plans for the future. For example, allied health appointments, ECG, blood tests, review of medications, and how you'd like to manage your own goals. These appointments are not for problems on the day. However, if you do have acute problems, like a cough or cold or something more serious, you can make an appointment on another day outside of this. But by working with the GPs and nurses this way, we will have more appointments on the day. So this is really important, increasing access for our patients. So we have patients coming to us for our care plan. We don't want to make it about osteoporosis. They're not coming to see us about osteoporosis. They're actually coming to see us about their pain in their feet, difficulty sleeping, getting in for a chat or getting out for a chat, or they don't like taking all these tablets. So it's our role as nurses to actually work with them, find out actually what are their problems, but actually what would motivate them to do something different. What do they enjoy doing? What are they not doing now? What matters to them? So we really need to emphasise what matters to them. So just talking about our care plans, they're not always the easiest tools, and I don't think they're always designed for patients, but they're there and they're what we've got. But instead of perhaps having falls prevention and the goal being prevent A&E attendances and the action attend physiotherapy once per month, we could start making it more I words. So it's the patient's plan. And so we say I need to build up my muscle strength to assist with balance. And the goal is to be able to use the stairs without needing any assistance. And then their action, the GP to refer me to the physiotherapist, which we've probably already done. I will discuss strengthening exercises with my physio or exercise physiologist. I'll join a weekly walking group. So quite often we have this, we tackle it at the end of the plan, but we put it at the top of the plan so that we can actually highlight for the patient, they can see what their goals are, what their actions are for the next 6 months. So I'm fortunate in my practice I get an hour for our care plans, and they're very comprehensive activities. So before the patient comes in, I have this little checklist that I go through. But one of the most important things that I really like to look at is bones. Have they got risk factors? Have they had a bone mineral density? What was their T-score? What was the date of it? Was it recommended a repeat date? Are there other factors that they should be coming for having a repeat? Are they at risk of falls? Have we seen some things in their notes? So I troll through the letters, the letters for the last 6-12 months. Who's been involved in their care? Are they already seeing specialists? Are they seeing exercise physiologists? How can we work on building the team with the team care that's already provided? Have they had a home medicine review? These are important factors. So we need to actually have a look at this before the patient gets into the room. And then once the patient gets into the room, we run through the checklist. And once again, we do that height, making sure that it's really important. And then we ask them about their bones. Have you had a fracture or broken bone since the age of 50? Were you surprised that you broke a bone? Have you had a fall in the last 6 months? Were you hurt as a result of these falls? What were you doing when you had a fall? Did you end up in hospital? A lot of this data is never captured in the notes, so this is your opportunity to find it and write it, document it. Okay, moving on. Now, the REFRAME program has a great template for osteoporosis, but in my clinic, most patients are having care plans for another reason, and osteoporosis is an added reason. So they might be coming for cardiovascular disease, they might be coming for diabetes, they might be having other things. So I've actually incorporated much of this information in our own care plan. Now, I say to my patients, who knows what this is? And they go, oh, is it a brain? And I go, no, actually, this is a cut through of your thigh. And this is when you're 25 and this is when you're 75. Did you know from the age of 40 onwards that we start losing muscle mass? And they go, oh, you know, Penny starts, yes, we've become a bit saggy since the age of 40, haven't we? And so we explain the only way to keep your muscles strong, because they're actually losing 1% of muscle mass per annum from the age of 40. So how do we keep that muscle strong? We've got to do exercise, so not only aerobic exercise, but some weight-bearing exercise. We need them to have protein in their diet. So 2 meals of protein a day, and this will help to build the muscles. Without the muscles, their functioning will be a lot less. They're going to be at higher risk of falls. So having some visual cues in your practice is really good for educating our patients about, you know, their longevity and how important their muscles are actually, because at the end of the day, that's going to, you know, keep them functioning, keep them moving, keep them out of that aged care facility, keep them upright. So this is what we want. Now, Mrs. O'Brien is a lady who came to see me about just over a year ago, and she was 80 and she'd had a fall. She'd lost her husband 6 months prior to this, and she'd lost her confidence. She's sitting in the chair a lot more, and she's going, oh, I'm just getting old, you know, my time's coming. She was really, you know, perhaps a little bit depressed, and but lacking motivation. And this is our skill, isn't it? With our motivational interviewing skills, how are we going to actually get Mrs. O'Brien back to exercise? This is the part for Mrs. O'Brien. So we've got to find out what matters to her. So, well, what are you doing now, Mrs. O'Brien, that you weren't doing, that you want to get back to doing? Or what were you doing 6 months ago that you want to start doing again? And so Mrs. O'Brien, she said, oh, look, my garden, it's getting so dry out there and I'm too scared, I can't get out there to, you know, to water my garden. And my little dog Bella's a little fluffy white thing that she actually really enjoyed going for a walk down the street, because she used to have a little chit-chat with Frank down the street. And she'd actually like to see Frank, but, you know, she's just lost confidence. So I spoke to Mrs. O'Brien and, you know, okay, we could refer her off to exercise physiology, physiotherapy, but she's actually lost confidence. So we actually need to work with our patients to actually show them a few little exercises on how we, you know, just to make a difference in their day. And so with Mrs. O'Brien, she's got a walking frame now, and I just showed her a few sit to stand exercises. And I said, do you think you can do that 3 times and do it twice a day? Oh, okay. So Mrs. O'Brien did it with a walking frame. Oh, yeah. And I said, well, you know, by the end of the week, I want you doing it 5 to 10 times. And then, perhaps when you're ready, you'll be ready for the exercise classes or to see the exercise physiologist. You know, and I talk to them about our great teams that we have with the exercise physiology, and they know a lot more than me about, you know, osteoporosis or exercises for osteoporosis, and they'll be able to tailor them to you, because we want you to keep on living well, living out in the community. And lo and behold, Mrs. O'Brien, I booked her in for a review with me in 3 months, but she came back and saw the GP at 6 weeks and said, I think I'm ready to get to the exercise classes. You know, can can you book me in? And of course the GP goes, oh, you have to see the nurse about that. Yeah. Okay, so the impact of falls. What's actually happening with our patients? Falls prevention is an important part of our health management in the elderly and those with osteoporosis. Greater than 60% of older people with femoral neck osteoporosis have fall-related risk factors. 90% of hip fractures result from a fall. So they're the major leading cause of injury-related hospitalisation for older people. So this is really costing the health system a lot. It's actually costing our patients a lot in their quality of life, and you know, their families are missing out on enjoying their and you know, no doubt everyone's got an older person in their life, and we don't want to see their life cut short by osteoporosis. So what can we do? So every patient with a minimal trauma fracture, we're going to add an action. We add it into the notes, highlight it. You know, we're going to talk about it with our GPs, with our admin staff, just to start being aware so that they can add that osteoporosis diagnosis to the past medical history. We've got to actually explain to our team how important it is to have coded diagnosis, and because for our data to actually know who is in our herd, we need a proper diagnosis. So we also, another thing I've found within practices is every patient on a medication hasn't always got a reason for that medication. And so we've got to teach our GPs, when they are prescribing, the reason we need to have a reason for medication is if we're printing the patient's health assessment, it's actually really useful for the patient to understand why they're on that medication. But also, they can add it to the past medical history if they just tick or untick that box in the clinical software. Family history. Now, those of you that work with best practice, you've got some great prompts in family history section on cardiovascular disease, depression, different cancers. Our medical director is just a blank canvas. So we have to remember when we're asking people about their their family history, just ask them and put it there. You know, have either of their parents had a fractured hip? In our health assessments, in our care plans, we've got to have something about bones. Just remember bones, and just get good at asking the questions and being aware of it. So, who can help? In our team care arrangements, we have a lovely list, and we try and include everybody as possible in the team care. And we give the patient the care plan, and we say take it with you to all your to your appointments so that they can see who else is in your team. You know, this is not the Medicare requirements, this is our own patients in our practice, that we're actually getting them to understand that it's not their GP who's the only person in their care. Oh yeah, the GP and the GP practice are actually coordinating the care, but there are all these other people involved. The exercise physiologist, the physio, the podiatrist, the dietitian. You know, the exercise classes they're going to. You know, I don't know, other states have Strength for Life, or we have these over 50 exercise classes, but quite often, you know, they would actually like to know a little bit of history, and so if the patient's willing to share, you know, they could show it with the personal trainer or the physio leading the class. Now, the aged care provider coordinator, this is really important. This is one of the things we found in our Healthy Ageing Clinic, that when we're going out to do these home health assessments, yes, we do them in the home, it's really important to say, oh, are you having any help for cleaning? Oh, yeah, we have, oh, don't know who it is. Oh, do they have a folder? Oh, yeah, there's something that each one signs off. Okay, grab that folder, have a look at who the care coordinator is. You know, make a phone call to that person. Just see if that patient's using all their package. Because what I've been finding is, you know, patients this group, a lot of these patients are using all their EPCs for podiatry. But we need them to be going to exercise. And so have they got capacity within their package? And these coordinators are quite often saying, oh no, yes, actually we do recommend, we've got exercise classes at our centre. Oh yeah, we've got, we could send a car and, I'm thinking, oh, the services are out there, they're just not being spent. So it's a bit of a fractured system, but if we can help our patients get there by coordinating their care with their aged care provider, that's even better. And also, they know who to ring if they've got a problem with the patient. So they don't always have to speak to the GP. They've got the nurse coordinating the care of the patient. Getting an OT in, the package might have ability for that. It's the pharmacist, home medication review. We know that the medications quite often are contributing to the patient's falls. But if we're going to get them back to, full strength, they need to have an HMR. Different states are doing health pathways with their PHNs, and sometimes we do need the geriatrician and the specialist input. So at the end of our care plans, our GPs come to our rooms and we have this conversation. We have the GP, the nurse, the patient. The nurse will facilitate the conversation and say, oh, Mrs. O'Brien, her goals today are she wants to get back to walking up a flight of stairs. She wants to go to the physio. And the GP can say, oh, that's a really good goal. Yes, and they can reinforce your role and back you up, have your back, have it as a team approach. And, our GPs are actually learning things from the nurses because we're looking at it with a different set of eyes. And I think, we're becoming a better team because we've got more people involved. We're also planning regular follow-up, 3 to 6 months, depending on our risk for our patients. So we let the GP leave our room, but before that patient leaves our room, we make sure they've got the appointment for the next one. They know we are booked out 6 months in advance, and then it's very hard to rebook. So they get their diaries out, we reschedule it there and then. I've found, in this practice it seems to work so much better than letters have, or, for patients to actually ring up for their care plan. The day before, some of your practice is probably using SMS. We're not quite as up to date at this stage, but it's something we'd like to look at in the future. But our practice staff they've worked there for 20 years. They know our patients really well. They actually ring the patient the day before, just remind them of their care plan, that they might have a script that they need some medication for, we would have sent a letter if they needed bloods, 2 weeks prior. But we've got systems in place to get our care planning happening really well. So before that patient leaves the room, it's important that we actually close the loop. So get that care plan printed out and highlight their role. What is their thing that they have to do in the next 6 months? Remind them to take that care plan with all their appointments. It's to be used as a tool of communication with all their healthcare providers. With our Healthy Ageing Clinic, we've actually provided the patient with a folder, and we put the health assessment in it, we put the care plan, and then we're building on it with other resources like personal alarms, with any other resources that you think are important to that person or their family. Perhaps the family wants some help with dementia care, so we put the Dementia Australia brochures in. So now, with patients that are on medication now, that may be having medication, it's important to have really good systems in your practice for reminders, and because we want them to stay on their treatment. So, if you need help with your recall and reminders, there's some great tools out there. Katrina Otto with Train IT, I've actually got her down to Adelaide into our practice to actually sort out our software and just, help us, because it was in quite a mess. We weren't using it to the best of its ability. She's actually done webinars with our GPs so that they can understand better about recalls and reminders. And she can be a phone call away. Take-home messages for GP nurses. Well, this is if you haven't learned anything today, I want you to understand how prevalent it is out in our community, why we need to find patients with osteopenia, osteoporosis, and how we can better manage these patients in our practice population. So I'd like to introduce the REFRAME program, and we've been working with the beautiful Sue Gregory in Adelaide, coming into our practice and helping us find these patients. So the REFRAME program looks at the lapsed patients diagnosed with osteoporosis and their therapy is stopped, looking at primary prevention and secondary prevention. They've got some fantastic resources. They have got a stand here, and you can pick up all those resources there. They've got a lovely workbook that you as nurses can work through. They've got tools for your patients, flyers for out in the waiting rooms to make everyone aware. Waiting room posters and the care plan that I showed you. So there is also the website. You can go on the website, register, and there are a whole lot of resources there that you can use straight away. And speak to your nurse educator in your area, and perhaps get them to come to your practice and have a lunchtime meeting or something like that, to help with the whole team get to understand REFRAME and osteoporosis. Thank you. Now, any questions at all? Yes. Could we have a microphone here, the lady in pink? Lady in pink down the front, that's great.
I have a question, and I also wanted to tell you something. I'm Susan from Armidale in New South Wales.
Just a bit louder, Susan.
I'm Susan from Armidale in New South Wales. So I wanted to tell you about a free online course in falls prevention that is offered. It comes from Kent University. I think it's Kent University in the UK, but it's through the website FutureLearn, and it's got some really great information, not only for nurses, but for clients who are
thank you for that.
Interested.
That's great.
And I wanted to ask you about people who don't continue their medication. Is it because of side effects, or what percentage is because of side effects, and what alternatives are there or management strategies are there?
Yeah, well, I might throw that to my REFRAME team.
Oh, it's futurelearn.com, and the course is Healthy Aging Falls. It's over 4 weeks, but it's like 4 hours a week, and you can actually access all the content right at once. And
yeah.
Some really good information.
Naomi, Susan asked patients adhering to their medication, what are the different reasons why they're not continuing?
I think there's many reasons. Usually it's just forgetting, plain forgetting. It's important, I guess, to encourage people to make a habit of, if it's a daily medication, put it next to your toothbrush, and if it's something that's got a longer period of dosing, well then I guess it comes down to the practice sending those reminders.
Yeah. So there are different medications out there, and it's part of your GP's clinical judgment. What medication do they think the patient would adhere to better? So there are choices. Next question. Okay. Oh, Megan, wait for the microphone, please.
I was just wondering, with the Prolia, how recent do you want the bloods before you give the Prolia? Do you accept like a calcium reading from 6 months ago, or?
I don't think that calcium and the blood score is any indication. We need them actually having calcium in their diet, and so we need 1,300 milligrams of calcium per day, and you'll be pleased to know if you look at the little calcium brochure, that may mean 26 scoops of ice cream a day, which I'm trying not to eat at the moment. The bloods I was referring to was more the diabetes, sending that form out 3 weeks beforehand. No, we're not looking at calcium in the blood. We're actually looking at calcium in their diet. Are they having enough?
Can I just say, before you do give Prolia, you should be checking their calcium, and you need to check that it's within the normal range because it does drop the calcium.
Right. Yes. Yes. Thank you for that. That's good, and probably that's what our GPs are doing. And
can you tell me a little bit about rechecking their bone mineral density? If they're osteopenic, when do you recommend it be redone, or if they're osteoporotic?
Well, I say, have a look at this RSCGP guidelines. That's got all the answers there, and it will say whether it's 2 years or 5 years, depending on their bone mineral density. And so it is a matter of the guidelines and following the guidelines. So do you have any more on that? No, I think, there is, whether it's 2 years or 5 years, sometimes if they've started treatment, it's after 1 year. So just going back to the guidelines. Microphone, here we are.
Hi, I've just wanted to know with your clinics, you're just incorporating doing this with your normal GP care plans that you're doing rather than just doing a one only, like a one focus, the osteoporosis.
Yeah. Osteoporosis is so across our whole community. So we started off doing this healthy ageing clinic, and it's just become a lot more prevalent. And so, we really like the nurses to get to know our patients. So if we can do the health assessment and the follow-up care plan, it is so much better with our us knowing our patients, and so we try and incorporate it all in together. Any other? Yeah.
Patients that have permanent implants, perhaps spinal rods, or children with multiple fractures, are they at greater risk sort of down the track?
Well, as you probably saw on that slide, people that are at risk are, people that are immobile, not exercising, we're growing our bones for the first 30 years of life, and we've got to have adequate calcium intake, vitamin D in that time to actually grow our healthy bones, because we start losing our bones. So, immobility is a risk factor for bone osteoporosis, osteopenia. Does that answer that?
Yeah. So those children with permanent implants it would benefit them to have care plans early and dietitian early or something like that, perhaps?
Yeah. If the GP sees fit that patient, would benefit from a care plan, it is a clinical decision of the GP, and they can decide whether they have a care plan. So not specifically about osteoporosis, but it's one of those grey areas, isn't it? Yes, Sue.
Hi, I'm Sue. I'm one of the REFRAME nurses.
This is the lovely Sue Gregory.
And I work here in Adelaide, so I'm not exactly sure whether having surgery on your spine would put you at more risk or not, but there is one specialist in osteoporotic care
who cause osteoporosis, a paediatric condition with geriatric consequences. And so that's just to get you thinking about the fact that you need to be looking after your bones throughout the lifestyle. And Jane showed you that slide and talked about it a moment ago about how bone turnover changes throughout the lifetime. So while we're younger, we're building up more bone. We get to our peak bone mass around 30 years of age, and then it's a slow decline, apart from in that postmenopausal period where it can be quite rapid. So I think we need to start thinking about kids, so making sure they're getting enough calcium and not spending so much time on their screens, but getting out and being active and putting stress on their bones. So I'm not sure about the answer to that question. I don't know if that would put them at more risk, but I guess if they're not getting the exercise, then that's something that's going to put them at risk later on in life.
Yes. Any other questions? Oh, yes. Jackie, down the front.
Just a quick one.
Yes.
Do you have any advice as to how long people can stay on Prolia for? Is there a maximum length of time?
Till the end of their days.
Right, okay.
Mm. Yes, I think that's what we're talking about, that they need to stay on medication forever. And, you know, quite often our patients, you know, they're still trotting off to that cardiologist and they might be 86 having their stat, but, you know, we've got to actually make them understand that the medication for the osteoporosis is probably a lot more beneficial to them than their statins at that stage of life. And so that HMR is really important. The GP needs to understand, you know, work with the patient about, you know, this is, you know, even if you're in a nursing home, it is important to stay on that medication because a hip fracture is, you know, the worst outcome for you. Oh. Thanks, Maggie. I don't know if that's my... I'm not here to speak about the drug, really. I'm here about the REFRAME program. Do they tolerate it well? Yeah. And, you know, if you've got a good recall and reminder system, they do tend to stay on it better than some of those other medications. One of the slides showed that. But, yeah, and I'm finding, you know, patients, oh yeah, that's much easier than, but, you know, different medications, and, you know, I've known some practices have done cluster infusions, and I haven't heard of that for a while, but, yeah, well, I think the 6 months injection is probably easier for the patient, yeah. Anything else?
Thank you, Jane.
Okay.
Thank you.
Thank you. So,
certainly learnt a few more tips. I love the tip about checking the folder in the patient's home.
Yes.
For the, to find out if their package is being fully used.
Yeah.
That was a great tip. Yeah.
So some of the great tools, you know,
Yeah.
go and grab them.
The little book for the patients is particularly useful because it's got beautiful pictures in it to show your patients as well. Yeah, so thank you, Jane. You've got the beautiful chocolate frog.
Thank you. I'm not sharing that with anyone, sorry.